Great. Okay, next we have a review of Verquevo from University of Utah.
Good morning. Can everyone hear me okay?
Yes, we can.
All right, let me just get the presentation here. All right, can you see the screen?
Yes.
Okay. Well, good morning. This presentation summarizes the April DUR report about the newly approved medication vericiguat. This report also reviewed pharmacotherapy recommendations for the treatment of chronic heart failure with a reduced ejection fraction to evaluate a potential place in therapy for vericiguat. This table provides an overview of the use of vericiguat. Vericiguat is indicated for the treatment of adults with symptomatic chronic heart failure with a reduced ejection fraction less than 45%, following a recent hospitalization for heart failure or use of outpatient intravenous diuretics. It has not yet been studied among children. Vericiguat is the first soluble guanylate cyclase, abbreviated SGC, stimulator indicated for the treatment of heart failure. Vericiguat stabilizes nitric oxide binding to SGC and directly stimulates SGC, leading to production of the secondary messenger cyclic GMP, which has numerous downstream effects. Among these effects is vasodilation and relaxation of smooth muscle. Vericiguat should be administered orally once daily with food to maximize absorption. It is started at a low dose and may be titrated as tolerated roughly every 2 weeks to the target dose of 10 milligrams daily. There are not dosage adjustments for mild to severe renal or hepatic impairment. However, it has not been studied in patients with end-stage kidney disease or severe hepatic impairment. Vericiguat can cause fetal harm and use is contraindicated during pregnancy. Additionally, it is contraindicated for concurrent use with another SGC stimulator, such as riociguat. There are various definitions and classification systems for heart failure. It is commonly categorized according to the degree of impairment of the left ventricular ejection fraction, abbreviated LVEF. A recent harmonized categorization from multiple heart failure organizations proposes the following categories based on degree of impairment of LVEF. That is, LVEF greater than or equal to 50% is referred to as heart failure with a preserved ejection fraction. LVEF between 41 to 49% is referred to as heart failure with a mildly reduced ejection fraction. And LVEF less than or equal to 40% is referred to as heart failure with a reduced ejection fraction. They also add a new category reflecting the possibility of recovery of the left ventricular ejection fraction, heart failure with an improved ejection fraction. Vericiguat is indicated for patients with a left ventricular ejection fraction less than 45%, which includes patients with a reduced ejection fraction and some patients with a mildly reduced ejection fraction. The severity of symptoms and degree of functional impairment is often classified by the New York Heart Association, or NYHA functional class. This system ranges from class 1, which is patients without any limitations in physical activity, to the most severe category, class 4, categorized by symptoms at rest or with any physical activity. Natriuretic peptide biomarkers, including B-type natriuretic peptide, or BNP, and N-terminal pro-B-type natriuretic peptide, or NT-proBNP, can be used to support the diagnosis of heart failure and assist with staging disease severity. Persistent elevation is associated with a greater heart failure severity and a worse prognosis. Overall management of heart failure with a reduced ejection fraction in adults, defined as those with a left ventricular ejection fraction less than or equal to 40%, includes treatment of underlying conditions, preventative care, pharmacologic therapy, device therapy, and surgical interventions. Goals of treatment are to improve survival, reduce hospitalizations and symptoms, and improve quality of life. Medications targeting the heart failure, neurohormonal cascade, and sympathetic nervous system are the cornerstone of treatment for heart failure with a reduced ejection fraction because Many have been shown to reduce mortality and heart failure hospitalizations. However, these medications have not been proven to have the same benefit for patients with heart failure with a preserved ejection fraction. The optimal treatment for heart failure with a mildly reduced ejection fraction is uncertain. This population is heterogeneous. Observational studies support that many of these patients may benefit from treatments recommended for patients with a reduced ejection fraction, yet the 2013 American College of Cardiology, abbreviated ACC, and American Heart Association, abbreviated AHA, guidelines suggest that treating patients with a mildly reduced ejection fraction like those with a preserved ejection fraction. Medications recommended for heart failure with a reduced ejection fraction that have been shown to improve morbidity and mortality are commonly referred to as guideline-directed medical therapy, which I'll refer to as GDMT. The 2013 ACC and AHA guideline, updated in 2017, recommends that GDMT, at a minimum, include a specific evidence-based beta blocker combined with a renin-angiotensin system, abbreviated RAS, agent, including an ACE inhibitor, ARB, or ARNI, to reduce mortality. The 2021 ACC decision pathway prefers an ARNI, that is sacubitril valsartan, over an ACE inhibitor or an ARB. Patients should also receive a loop diuretic as needed for fluid overload. A mineralocorticoid receptor antagonist, such as spironolactone or eplerenone, is additionally recommended to be added to the combination of the ACE inhibitor, ARB, or ARNI with a beta blocker in specific patients as listed on this slide. All of these medications should be titrated as close to the evidence-based target dose as possible. Additional medications mentioned in the ACC-AHA guideline or other guidelines as part of GDMT include the combination of hydralazine, isosorbide dinitrate, avabradine, and SGLT2 inhibitors. These medications may be added to the previously mentioned GDMT in patients with persistent symptoms that meet the recommended criteria. In the ACC-AHA guideline, hydralazine isosorbide dinitrate is recommended for African American patients with an NYHA class 3 or 4 symptoms despite prior GDMT. Avabradine is recommended for symptomatic patients on GDMT that includes a maximally tolerated beta blocker that have a resting heart rate greater than or equal to 70 beats per minute and are in sinus rhythm. The 2021 ACC decision pathway recommends adding an SGLT2 inhibitor, either dapagliflozin or empagliflozin, for patients with the left ventricular ejection fraction less than or equal to 40% and NYHA class 2 to 4 symptoms that have already been treated with a RAS agent, beta blocker, and mineralocorticoid receptor antagonist. Vericiguat has not yet been incorporated into clinical practice guidelines for heart failure. Despite available evidence-based treatments for heart failure with a reduced ejection fraction, morbidity and mortality remains high. Observational studies have demonstrated that many patients do not receive the recommended GDMT or do not receive the target doses. So vericiguat, moving on to vericiguat, the efficacy of vericiguat for heart failure patients with a reduced ejection fraction was established in one phase 3 randomized double-blind placebo-controlled trial called the Victoria trial. This table summarizes some information from this trial. Patients included in the trial were adults with symptomatic chronic heart failure with a left ventricular ejection fraction less than 45%, who had a recent heart failure event, which was either a hospitalization for heart failure within the prior 6 months or received intravenous diuretics within the prior 3 months. Additionally, patients had to have an elevated either BNP or NT-proBNP level above a specific threshold. Patients were excluded for various cardiac and non-cardiac reasons. Among these include a recent clinical instability, such as symptomatic hypotension, and patients with severe or end-stage heart failure that had a requirement for continuous intravenous inotrope, implantable ventricular assist device, or those who are awaiting cardiac transplant. Overall, approximately 5,000 patients were randomized to vericiguat 10 milligrams daily or placebo, which was added on to guideline-directed medical therapy in accordance with clinical practice guidelines. Enrolled patients had a mean age of about 67 years with a mean left ventricular ejection fraction of about 28%. About 40% of patients had NYHA class 3 or 4 symptoms. Utilization of guideline-directed medical therapy seems similar to other recent heart failure trials. Approximately 60% of patients were receiving the combination of a RAS agent with a beta blocker and mineralocorticoid receptor antagonist, and 91% of patients were on at least 2 other medications, which is any RAS inhibitor or mineralocorticoid receptor antagonist in combination with a beta blocker. Though, while similar to other contemporary trials for dapagliflozin and empagliflozin, only 14.5% of patients were receiving an ARNI. Vericiguat demonstrated a statistically significant 10% relative hazard reduction in the composite of time to first hospitalization for heart failure or cardiovascular death versus placebo over a median of 11 months. The point estimates for the secondary outcomes of cardiovascular death and hospitalizations for heart failure also favored vericiguat, although they were not statistically significant. Most subgroups of patients treated with vericiguat seem to benefit from treatment other than patients with the highest NT-proBNP levels at baseline. Vericiguat has also been studied in heart failure patients with a higher ejection fraction that is greater than 45% without a clear demonstration of benefit. Vericiguat has a black box warning for the risk of fetal harm, which may include malformations of major vessels and death. Product labeling specifies that female patients of reproductive potential should confirm the absence of pregnancy prior to starting vericiguat, and that effective contraception should be used while taking vericiguat and for 1 month after stopping vericiguat. PDE5 inhibitors such as sildenafil should not be used with vericiguat due to the risk of hypotension. There is limited experience regarding concurrent use of vericiguat and long-acting nitrates or nitric oxide donors in patients with heart failure, since these patients were excluded from the Victoria trial. In a pharmacodynamic drug interaction study among coronary artery disease patients, some of which had heart failure, patients receiving the combination of a long-acting nitrate plus vericiguat 10 milligrams daily for 2 weeks had minimal changes in heart rate or blood pressure, and those observed changes were not considered symptomatic. Across clinical trials, adverse events occurring more frequently than placebo and among 5% or more patients included hypotension and anemia. In the phase 3 clinical trial of patients with heart failure with a reduced ejection fraction, anemia occurred among 7.6% of patients receiving vericiguat versus 5.7% of patients receiving placebo. The place in therapy of vericiguat in the treatment of heart failure with a reduced ejection fraction is not yet defined by clinical practice guidelines, as vericiguat was studied as an addition to other guideline-directed medical therapy, which for most patients included an ARNI or ACE inhibitor or ARB in combination with a beta blocker and mineralocorticoid receptor antagonists, as directed by guidelines. Its likely role in therapy is as an add-on medication for patients with persistent symptoms that have similar characteristics to patients included in the pivotal phase 3 trial. Historically, clinical practice guidelines for heart failure with a reduced ejection fraction have emphasized treatments with demonstrated benefits on mortality. Among various add-on medications, mineralocorticoid receptor antagonists, dapagliflozin, and hydralazine isosorbide dinitrate have demonstrated benefits on mortality in the populations in which they were studied and with differing standard background therapies at the time of their studies. Like the SGLT2 inhibitor empagliflozin, vericiguat did not demonstrate a statistically significant reduction in cardiovascular mortality alone in the heart failure population, but it was for a shorter duration trial and may have been underpowered. Compared to the SGLT2 inhibitors dapagliflozin and empagliflozin, which were compared to placebo in the DAPA-HF and EMPEROR reduced trials that included patients with heart failure with a reduced ejection fraction on similar background guideline-directed medical therapy, vericiguat demonstrated a similar absolute rate reduction for the primary composite outcome. However, the patient population of the Victoria trial differed. Compared to the heart failure trials with dapagliflozin and empagliflozin, the Victoria trial targeted more high-risk patients, including more patients with a recent hospitalization for heart failure, greater symptom severity, and in general, a higher NT-proBNP level. Information about the benefits of SGLT2 inhibitors for heart failure is emerging. A recent systematic review and meta-analysis demonstrated that compared to placebo among patients with heart failure, SGLT2 inhibitors reduce heart failure hospitalizations, cardiovascular death, and all-cause mortality. SGLT2 inhibitors also reduced renal events in heart failure patients. These results seem consistent among heart failure patients with or without diabetes. Since many recent advances in medications or other procedures for heart failure with a reduced ejection fraction have been conducted relatively concurrently, there is minimal information about the combined safety and efficacy of all possible indicated guideline-directed medical therapy. Few patients in the Victoria trial were also receiving an SGLT2 inhibitor. Overall, selection among add-on therapies may consider the demonstrated benefits, specific indications for use, as well as patient-specific characteristics that might make selection of a particular medication useful. For example, a recent expert opinion article by Lee et al. Proposed that an example of a good candidate for vericiguat might be a patient with heart failure and reduced ejection fraction on a background therapy of an ARNI and beta blocker and mineralocorticoid receptor antagonist that was recently hospitalized. Okay, so in summary, vericiguat is the first soluble guanylate cyclase stimulator indicated for the treatment of adults with symptomatic chronic heart failure with a left ventricular ejection fraction less than 45% and recent heart failure event, including hospitalization or intravenous diuretic use. In the pivotal clinical trial for the indicated population, the Victoria trial, vericiguat demonstrated a statistically significant reduction in the composite primary outcome of time to first hospitalization for heart failure or cardiovascular death versus placebo over a median of 11 months. The most common adverse effects occurring numerically more frequently than with placebo were anemia and hypotension. Recommendations for vericiguat are not yet available in clinical practice guidelines. Overall, vericiguat is an option as an add-on therapy to recommended guideline-directed medical therapy among patients with similar characteristics to patients in the Victoria trial. Among patients with heart failure and a reduced ejection fraction, guideline-directed medical therapy should include a beta blocker with either an ACE inhibitor, ARB, or ARNI, with or without a mineralocorticoid receptor antagonist, as indicated, that are ideally titrated to the maximally tolerated dose. Vericiguat is contraindicated for use during pregnancy due to the risk for fetal harm and also in patients receiving another SGC stimulator. It is not recommended for use with PDE5 inhibitors due to the risk of hypotension. So prior authorization criteria may be considered, and some considerations are included on this slide, and I know will be presented by the pharmacy team shortly. Some recommendations to consider include an age greater than or equal to 18 years old, having a diagnosis of chronic heart failure with a left ventricular ejection fraction less than 45% with a recent heart failure event, which includes hospitalization in the prior 6 months or IV diuretic use in the prior 3 months, and providing attestation that vericiguat will not be used during pregnancy concurrently with another SGC stimulator or concurrently with a PDE5 inhibitor. Additional possible criteria include documentation of a recent elevated BNP or NT-proBNP levels at or above the threshold criteria from the Victoria trial, and the requirement that patients starting vericiguat are already receiving recommended guideline-directed therapy unless contraindicated as recommended by clinical practice guidelines. There are additional safety considerations for use of vericiguat. For example, vericiguat has not been studied in patients with severe renal impairment. Anemia is a potential side effect of vericiguat, and anemia is a common condition among patients with stage 5 chronic kidney disease. Additionally, other patients were excluded from the Victoria trial, including clinically unstable patients and patients with end-stage or severe heart failure with a requirement for the continuous IV inotrope, an implantable ventricular assist device, or awaiting heart transplant. Use while breastfeeding is not recommended, and there is limited data about concurrent use with long-acting nitrates. Women of reproductive potential should ensure use of adequate contraception during use and for 1 month after stopping vericiguat. And these considerations may be additionally considered for part of PA criteria or as other educational information. All right, thank you for your attention.
Thank you. All right, so now we have the prior authorization discussion.
Thank you. Let me go ahead and present our criteria. So we have a few criteria for the vericiguat. So the patient is 18 years of age or older. The patient is not pregnant or breastfeeding, not taking soluble guanylate cyclase stimulator, such as riociguat. Patient not taking phosphodiesterase type 5 inhibitor, such as vardenafil, tadalafil, sildenafil. The patient is diagnosed with chronic heart failure with an ejection fraction of 45 or less, who are New York Heart Association class 2 to 4, and either hospitalized due to heart failure within the last 6 months, or require IV diuretic as an outpatient within the previous 3 months. Patient is concurrently receiving the maximum tolerated or target dose of guideline-directed medical therapy for heart failure, unless not tolerated or contraindicated. Should be taking beta blocker, such as carvedilol, metoprolol succinate, or bisoprolol. Angiotensin antagonist, such as ARNI, ACE, or ARB. Mineralocorticoid receptor antagonist, like spironolactone or elebron, if left ventricular ejection fraction less than 35 or less than 40 with diabetes or post myocardial infarction with heart failure symptom. With initial authorization will be up to 6 months and re-auth is 1 year.
Any comments or questions? Do we have any public comment
Not today.
on the agenda? No, thank you.
Do we need a resolution to approve this?
Yes.
Yes.
So my resolution is that we approve these guidelines or prior authorization.
I have a quick question. Are the SGLT2 inhibitors in the heart failure guidelines right now?
To my understanding, the SGLT2 is also an add-on to the guideline-directed medical therapy.
They're not yet in the major ACC/AHA guidelines because those were last published in 2017, although a new edition is expected this year. They are in the ACC 2021 decision pathway, which isn't a formal guideline. And then they're also in the American Diabetes Association guideline.
Great, thanks.
I'll second the motion, and I want to thank you for synthesizing what's an enormously complicated clinical set of guidelines and a very complex medication management scenario here. So if I understood what you just said about the current guidelines situation, if we're anticipating another set of professional guidelines to come out, is this then trying to bring our authorization and recommendations in line with what we anticipate is coming out shortly? Does anybody know?
I'm not sure what will be exactly in the new ACC-AHA guideline. I imagine it might be similar to the 2021 ACC decision pathway, although vericiguat was not in that pathway yet either, so I can't anticipate for sure whether this would mirror that, but the criteria do seem to be similar to the evidence we have based on the Victoria trial.
Okay, so then what I guess we would likely want to do is anticipating there's a major professional guideline coming out this year is make sure we see that when it is released, and make sure that our criteria are in line with that. I don't expect there's any major study that you haven't seen or synthesized here, but if somehow the guideline is released and we're off in some way with our criteria, then I would want these to be revised. I don't anticipate that, but I think if we do have another guideline coming out, within the year, then we should take a quick look and make sure that this is consistent. How do folks think about that?
Yeah, it's an excellent suggestion. I think it makes sense. So to the resolution, we add, what you just suggested.
I'm not sure I'm not sure how that would be, formally incorporated in the prior auth criteria, but I think we just have to make a process note, somewhere in our minutes, in that the committee knows that, and you all would we review the PA criteria, or we have some, let's see, where are we? We're in April. So somewhere 6 months from now, or somewhere along the way, we check to see if those guidelines are available, and do an internal check.
Yeah,
So-
and to that, oh, sorry.
I was just, go ahead, Jennifer.
Yeah, I was just going to note that as a standard for the pharmacy team, we do review all prior authorization forms annually. So they're clinically reviewed, the guidelines are checked, and usually the work is done towards the end of the year as we're setting up our new PDL for January 1st of 2022. So at that point, we would be reviewing clinically as well as looking at utilization and all of that. So it would be at a minimum reviewed towards the end of the year. Okay.
Are there any thoughts about adding something in here about the renal and hepatic dysfunction, like as an exclusion, just because it hasn't been studied in that group?
I wondered about that. I have a practice area for patients who are very advanced disease, and as we know, patients with end-stage heart failure often have accompanying organ involvement, both renal and hepatic dysfunction, and so I wondered. These clinicians taking care of these patients, obviously part of the goal is to see those call those kind of corollary organ dysfunctions improve as well. So I was wondering what, that I don't know that that's an absolute contraindication. How would we put that in there, or how would we account for that? that's a clinical reality. And a lot of times if you can see, you know, I'm not familiar with this new agent, and I don't do the primary care of these patients in terms of managing the heart failure, but I see these regimens, and, you know, I'm doing the other parts of the symptom management while these patients are being managed by their cardiology specialists and other specialists. And I'll see see if they can have improvement in their heart failure, then their renal and hepatic functions will also improve. So, what do other people think about, you know, how do we account for that?
I mean, I'd
This is
probably
Joe with
say,
the.
go ahead, Joe.
Please.
Oh, sorry, Dr. Smith. But just quickly for the committee's benefit, on some prioritizations, we'll say something, especially for new drugs, where we're still learning about it. We'll say something like you should monitor according to the package insert or according to guidelines, the manufacturer's recommendations. So as those recommendations change, we don't have to go back and change the PA form every time. I'm sorry, Dr. Smith.
Yeah, no, thank you. I was just going to say maybe excluding only severe, like maybe somebody awaiting transplant, that kind of thing, not just the more typical renal kidney dysfunction that you might see. Just because you're not getting a ton of benefit out of this drug, I'm not sure it's worth, you know, the kind of unknowns in that group.
Didn't we see there's an exclusion for patients awaiting cardiac transplant? Lauren, didn't we see that?
I mentioned that those patients were excluded in the Victoria trial. I mean, it's not listed as an exclusion on the product labeling.
Oh, gotcha. Thank you. There's so much information. I lost a detail there. So is it? So are we thinking maybe to put the exclusion here for consideration to exclude patients with end stage organ failure of various, you know, the various organs, but then we'd have to define what that is. Whether that be heart failure, renal failure, kidney failure. Dr. Gregaro?
I was just thinking, you know, again, I liked what Joe mentioned about the information of monitoring, you know, in per the package insert type thing versus like, I think we're gonna, I don't know how to articulate this, but I worry that even though those individuals were maybe excluded from that particular trial, having like the hard stop on here and all the intricacies and defining of what that exclusion criteria is may be a little too much in this prior authorization form. And so I would propose that we add the language about monitoring per the package insert versus a strict exclusion for the end stage organ failure.
Well, how about instead of a strict exclusion, a not recommended for, you know, due to lack of available data? And yes, also the recommendation about following the monitoring on the package insert.
Could that be
So
just
we
an
did-
asterisk down at the bottom? You know, before, right above reauthorization criteria, place an asterisk that says not studied in patients with an EGFR less than 15 or on dialysis and not studied in patients with severe hepatic impairment. And just put that in bold down there as a kind of a,
Yep.
not a warning, but just an alert to the person filling out the PA.
Sure.
I like that.
That would be above the reauth criteria.
Yeah, above the reauth criteria.
One more up. And And so do we want to say, so we're recommending monitoring, or?
I'm
Or-
not just an asterisk, just making a warning. It just says not studied in patients with an EGR less than 15 or on dialysis, and not studied in patients with severe hepatic impairment.
Right. And so that's an educational note to someone who would be looking at the PA criteria form. Okay.
And then it sounded like we would also add the language about the monitoring per package
Yes.
guide.
Or for the package, it's
Beautiful.
got it. I see it's in there. Yeah, yeah.
Beautiful.
I would say that the recommend monitoring according to package insert would be like a separate thing from that note versus saying that, hey, this has not been studied in this population, so we recommend monitoring according. It hasn't been studied in these populations, and because it's a new medication, we recommend per package insert.
Right, because what should be monitored probably is the H&H, it's not connected per se to the renal or hepatic, so it's not like they're doing extra monitoring on renal or hepatic function. Good.
In the line about the mineralocorticoid receptor antagonist, it might be missing LVEF less than or equal to 40% before the, yeah.
Dr. Heath, could I ask you to go back to the SGLT2? You made comments about them, and I'm just a little slow this morning. There's no comparative data between SGLT2s. Do you think, for example, the ACC is going to have some kind of a treatment algorithm that will place these equal, one in front of the other, one behind the other? I know that's a big guess.
Yes, I would just be guessing. I'm not sure what they'll do. I mean, I can say that only 3% of patients in the Victoria trial were on an SGLT2 inhibitor. In the ACC 2021 decision pathway, they currently have kind of a flow where they recommend adding medications in a certain order. I don't know which order they would recommend for SGLT2 inhibitor versus Victoria trial. I would guess it would be more in line with the certain patient characteristics in which they were studied. But I don't know how they'll prioritize them.
And clearly, if patient had diabetes, an SGLT2 added, I mean, that's an easy one. But now the data, and correct me if I'm wrong, shows effectiveness, decrease in mortality, even in patients without diabetes. So
that's correct. It seems to be independent of diabetes status. And the two dapagliflozin and empagliflozin that are specifically studied in patients with heart failure with reduced ejection fraction enrolled patients with and without diabetes and demonstrated benefit.
And Joe, on page 17 and 18 of that report is a really nice table comparing the benefits of those.
Thank you, Dr.
And sort of
Weinstein.
lining up the different studies. Yeah, that table kind of was leading me to, like, should we have SGLT2s on here as another thing to try, like another step maybe.
I don't know that we necessarily have enough data or official guidelines to include that yet. That may be something that when it's reviewed after the next set of guidelines come out at the end of the year, we may need to consider adding, but I don't know that we have enough data or evidence at this point to include it.
I agree with that. I think we're wait till guidelines come out and then we can make a more accurate decision.
Sounds good. Any other comments?
I would just say that from the note of medication has not been studied, I would suggest hepatic insufficiency versus hepatic insufficient.
Good catch. All right, are we feeling ready to approve here? We have a motion on the table. Did we get a second?
I did.
Motion to approve based on the adjustments made.
Mm-hmm. Great, thank you.
I'll second the amended motion as well.
Thank you, Dr. Weinstein. All right. All in favor of approving the latest motion, say aye.
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 Any opposed? Abstentions? All right, our new criteria are approved. All right, next on the agenda, we have the continuation of care policy.
All right. Good morning, everybody. Let me know if you can't see this slide here. So there's a scenario that happens often when patients switch from Medicaid ACO to fee-for-service, or who are newly eligible for Medicaid fee-for-service. And these patients are usually already or often already stable on certain prescription medications, some of which are not preferred on our PDL and require prior authorization. So this policy that we developed is to address those prior authorizations that come in for non-preferred medications that patients are already established on, to number one, make sure that we are using the most cost-effective medications on our PDL, but also not interrupting care for patients who are coming to our plan. So we did not previously have this policy that led to less uniformity in how we as technicians and pharmacists would evaluate it. And the development of this is to make sure that we evaluate it in a way that is uniform for all of the technicians and all of the pharmacists. So we have the definition up top of continuation of care. We determined that it is defined as evidence of the patient being on the requested medication for a minimum of 60 out of the last 90 days. We chose this definition. We know there will be variability based on the disease state or the medication, but wanted to choose more specific time frame to evaluate this. And one of the things that we had discussed a lot prior to having this policy was which supporting documentation is enough for us to justify an approval. And so we also outlined the supporting documentation that we will accept or use to support an approval below. So that includes chart notes. Sometimes those are not included. So we wanted any email messages with conversations between us and the prescriber at the clinic, any fill history obtained from the controlled substance database, or if we call the dispensing pharmacy and obtain claims history that we don't have because we are their new plan. A letter of medical justification from the prescriber demonstrating why clinically the patient needs the medication. And then we will also take verbal or written attestation, so written on the prior authorization form of medical need, or if we call the office and have a conversation about the patient's need for the medication that's not preferred. So this policy has been approved and it will be published in the pharmacy manual starting May 1st. Does anyone have questions on it?
You capture text messages?
We did not.
I have a, it's one of my pet peeves, sorry.
Oh, I believe you.
How much care now is being accomplished by text? Oh, goodness.
And like one thing that I know we have taken is like if we call the office and we take conversation or messaging through the EMR, that is something we've used to support approval before as well. So not quite text messaging, but.
Hey, Stephanie, this is Eric. I mean, do you want, where you're asking for chart notes, I hate the notion of chart notes coming in and they send 200 pages and somebody is left to sort through those to find what they're looking for. I mean, can you say letter of medical justification, you know, supported by, you know, specific chart notes or supported, I'm just thinking operationally for you guys.
Relative chart notes?
Yeah, I mean, something that just says we don't want the patient's entire
Yeah.
chart. We just,
Well,
Right.
and to
So
be
we
honest,
actually,
Right.
go ahead, Jen.
yeah, just one thing. This is to provide, the purpose of this was to provide some framework for the team. And it's going to be published in our manual. This isn't going to be, put onto any prior auth or anything. But to your note, I think not receiving 200 pages is something that is worthwhile to mention as well. But this will go into the pharmacy manual, but it's really serving as some guidelines for the staff of what is acceptable. Does that make sense?
Yeah, so you're talking about relevant chart notes, and
Yeah.
and the reason I said text is because I just yesterday got, a text from one of my clinic nurses asking if I could please, provide them the, essence of the medical necessity for why I requested a medication on, patient the day before, and it goes back through a text. And this is the way care is being provided now. Why I prescribed the medication is in the chart note from the day before. So they can send that chart note, and it's one chart note. They could also send the last 14 years worth of chart notes for that patient. But this is hopefully we're not sending you, 200 chart note pages.
And I think that's pretty rare.
You want to say, relevant chart notes, but.
And
again,
I think most of the time, the chart notes we receive are.
Yeah, hopefully people use judgment, right?
Mm-hmm.
Yeah, like Brian said, that's really a rare occurrence. Also, I believe, and I'll have to double check, but on the medication exception form that they'd be submitting this on, it has in like big, bold, all caps, please submit relevant documentation. It doesn't just say, occasionally we'll be like, oh, this provider sent in 150 pages of chart notes, but that's like a pretty one-off occurrence.
So this is for exception. This is for exception only, the continuation of care policy?
Right, because if it's something that's preferred and doesn't usually require a PA, then we're not even going to see an authorization request because it's something where they can just process it at point of sale at the pharmacy.
Okay, so this particular document's only going to show up under the exception area in the website?
Right, so non-preferred and, brand generic.
Any other comments or questions? All right, hearing none. I guess our next meeting is Thursday, May 13th, where we will be discussing Reduxistat. And is there a motion to adjourn?
Move to adjourn.
Thank you.
I just
Second?
barely beat you, Kamara. Come on.
What's that? Sorry, I didn't.
All the
didn't-
good that we were going to do, we have already accomplished today. So till the next time, be safe and sound.
Agree. Thank you. All right, we are adjourned.
Thank you
Have
all.
a good one, everybody.
Have a great day, everyone.
A wonderful day.